Chapter 16, Trauma, Stressor-Related, and Dissociative Disorders. So this chapter will cover several factors, including those related to trauma, such as sexual, physical, or emotional abuse, severe neglect, repeated abandonment, or experiencing a sudden loss. These traumatic life events are associated with a wide range of psychiatric and other medical disorders, especially the dissociative identity disorders. Trauma-informed care should be incorporated into all aspects of healthcare to ensure that patients get early interventions that are necessary. Okay, attachment disorders. First, we will discuss trauma-related disorders in children that include attachment disorders and PTSD. Attachment disorders are psychiatric conditions in children who have problems with emotional attachments to others. They are caused by a grossly inadequate nurturing environment, deficient in bonding experiences with a primary caregiver by the age of 8 months. A reactive attachment disorder is a condition in which a child does not form healthy emotional bonds with the caregiver by 8 months old. The child rarely seeks comfort or responds to comfort with adult caregivers when they are distressed. Disinhibited social engagement disorder is an attachment disorder that makes it hard for children to form an emotional bond with others. They have no fear of strangers and are unfazed by separation from their primary caregiver. Younger children may allow unfamiliar people to pick them up, feed them, or play with them. These children tend to become overly friendly and are usually willing or even eager to go with someone they do not know. So some risk factors can be neurobiology or environmental, and they usually stem from a child that is in foster care or an institutional setting. However, both of these two disorders are very rare. Now, there are lifelong interpersonal relationship consequences if these disorders are not treated. But usually children are resilient and can adapt quickly with the proper treatment. Treatment always involves both the child and the caregivers in individual and family therapy. A primary goal of care is to strengthen the relationship between the child and the caregiver. A safe and stable living environment is also essential to improving attachment behaviors. PTSD in children and adolescents. Children do not have adequate coping skills to handle or witness a traumatic event. Nearly all children who witness a parent's murder or sexual assault will develop PTSD. So clinically, PTSD in preschool children may manifest as a reduction in play. Play that includes aspects of the traumatic event, social withdrawal, and negative emotions such as fear, guilt, anger, horror, sadness, shame, or confusion. Children may blame themselves for the traumatic event. In addition, there may be a feeling of detachment or estrangement from others and diminished interest or participation in significant activities. Often, there is irritability, aggressive or self-destructive behavior, sleep disturbances, problems concentrating, and hypervigilance. Comorbidities. Children may experience nightmares, phobias, difficulty with impulse control, sleep disturbances, learning and attention problems, behavioral problems, and possible substance use problems. Children and adolescents who have suffered toxic stress and trauma often meet the criteria for more than one diagnostic category. Even if a child does not have sufficient symptoms for a diagnosis of PTSD, he can still suffer from overwhelming nightmares or difficulties with trust, phobias, somatic problems, impulse control, and identity issues. Learning and attention problems, behavioral problems, sleep disorders, depression, suicide attempts, disassociation, and substance abuse problems are all significant comorbidities. These comorbidities expose children to an endless cycle of medications, punishments, and inadequate responses that re-victimize and stigmatize them. Now, risk factors, biological, genetics has been shown to play a role in the stress response that contributes to the development of PTSD. Neurobiological, trauma will dysregulate neural pathways that integrate emotional regulation and arousal. Triggers hypoaroused state leading to disassociation. The polyvagal theory suggests that the autonomic nervous system goes beyond the fight or flight response. So let's talk about a normal stress response. In a normal stress response, the hyperarousal in the sympathetic system is balanced by the parasympathetic system. When a person senses danger through the eyes or ears or both, this information is sent to the amygdala. The amygdala interprets the sensory input. Neuronal circuits connect the amygdala to the prefrontal lobe in the cortex. The prefrontal lobe serves as the translator of the emotion so that the amygdala activation can be modulated. The prefrontal association area keeps track of where information has been stored in long-term memory. This area is then responsible for retrieving and integrating memories with sensory input for decision making. But what about a trauma stress response? Repeated stress and trauma can cause changes in the brain as well as hormonal imbalances in the body. Recurring experiences with trauma or stress will result in frequent activation of the HPA axis, which leads to elevated levels of stress hormones. Elevated stress hormones influence the immune and inflammatory systems. Infrequent activation of the HPA axis when the brain is developing can result in gene expression that may ultimately influence adult emotional and cognitive behavior and functioning. Following exposure to violence and trauma, the parasympathetic response triggers a hypoaroused state with dysregulation of the hypothalamic pituitary adrenal, the HPA axis, that may result in disassociation. Disassociation is a disconnection of thoughts, emotions, sensations, and behaviors connected with a memory. Some disassociation is considered a normal experience for most people, such as when we zone out during a movie or when driving. However, severe disassociation or mind flight occurs for those who have suffered significant trauma. The episodic failure of disassociation causes intrusive symptoms such as flashbacks, thus dysregulating cortisol, resulting in either too much or too little of the hormone. Environmental, combination of dependency children have on others and neuroplasticity, which is the brain's ability to adapt as a result of life experiences. External factors in the environment include school, parents, poverty, and culture. And then here's a term you should know called resiliency, which is the ability that most children have in which they can adapt positively to a situation and regain their mental health. Now, manifestations, as you see, reduction in play or play reflecting aspects of trauma, self-blame, detachment, estrangement, loss of interest in significant activities, mood changes, sleep disturbances, hypervigilance, and loss of concentration. Hypervigilance means constantly assessing for potential threats. All right, so assessment. The number one goal in assessment with these people is to establish rapport. Period. In the discussion. But the assessment is ongoing throughout the child or adolescent's treatment. Mental status and physical symptoms are important to identify, as well as appearance, social functioning, speech, safety, and coordination. Now let's talk about essential assessment data. This is going to include post-traumatic symptoms such as nightmares, memories, thoughts, flashbacks, numbing, or avoidance of the trauma. And then the developmental assessment is an assessment of the child's developmental or maturity level. We've mentioned this one before, but the Denver 2 developmental screen tool is used for infants and children up to age 6 years. And you need to remember that these findings in the developmental assessment may be temporary and related to the trauma itself, especially if they regress. Nursing diagnoses, priority nursing diagnoses that have been identified related specifically to PTSD include post-trauma response, impaired caregiver-child attachment, impaired adolescent development, but the number one priority diagnosis is depression. For outcome identification, you can see here on page 297, you want to see an improved response to trauma, improved caregiver-child attachment, and an improved adolescent development. Now, implementation. There are going to be 3 stages here. The first stage is to provide safety and stabilization. The second stage is to reduce arousal and regulate emotion through symptom reduction and memory work. And the third stage involves catching up on developmental and social skills, as well as developing a value system. Maintaining a window of tolerance is important to provide balance between the sympathetic and parasympathetic nervous systems due to the difficulty children have fluctuating between hyper and hypo arousal states. And then evaluation. Your treatment was effective when the child's safety has been maintained, anxiety has been reduced, and stress is handled adaptively. Emotions and behavior are appropriate for the situation. The child achieves normal developmental milestones for his or her chronological age, and the child is able to seek out adults for nurturance and help when needed. So interventions for a child with PTSD. Use an interactive process. Establish trust and safety. Use developmentally appropriate language. Teach relaxation techniques before trauma exploration to restore a sense of control. Use art and play to promote expressions of feelings. Involve caretakers in one-on-one unless they are the cause of the trauma. Educate child and caretakers about grief process and response to the trauma. Assist caretakers in resolving their own emotional distress about the trauma, and coordinate with social work for protections. Make sure that you show empathy and acknowledge the child's distress. Remain calm. Use a low, comforting voice, and explain and reinforce the reality of the situation to avoid any distortions. So treatment modalities, psychological therapies are considered the first line treatment for traumatized children. We've already talked about CBT, cognitive behavioral therapy, so I'm not going to go back into it on this one. But let's talk about EMDR, which is eye movement desensitization and reprocessing, in which the individual concentrates on an emotionally disturbing material in brief sequential doses while simultaneously focusing on an external stimulus such as eye movement or tapping sounds. This therapy may help to process and integrate your traumatic memories. And then you have your biological treatments, so various pharmacotherapies that can be a combination of these, and then target symptoms and comorbidities such as ADHD or major depressive disorder. So evaluation of treatment for a child with PTSD. Treatment is effective in, we've already mentioned that, so I'm sorry, that's a repeated slide. Max, age 6, has been traumatized by a history of violence from an alcoholic father. A neighbor calls the police one night, and the father is taken in for questioning and agrees to enroll in rehab. Max is taken to the hospital for assessment of his arm, which is covered with bruises. His mother is distraught and says she wants help for the whole family, including her husband. The nurse prepares to assess Max's mental health. Which of the following should be established first in working with a child with PTSD? A. Provide safety and stabilization. Before going home from the hospital, Max and his family begin intervention therapy, which is probably the least useful strategy at this time. C. Bring Max's father into one-on-one play therapy sessions. Because Max's dad has been the cause of the trauma, it is not yet appropriate to bring his father in for one-on-one play therapy. So PTSD in adults. So from here on, we're going to discuss trauma-related disorders in adults. That includes PTSD, acute stress disorder, and adjustment disorders. So PTSD invokes the same feelings of intense fear, helplessness, and horror in adults as it does in children. As in children, the major features of PTSD include the following. 1. Re-experiencing the trauma through recurrent intrusive recollections of the event or dreams about the event. Flashbacks are dissociative experiences during which the event is relived along with vivid sensory input. Avoidance of stimuli associated with the trauma, causing the individual to avoid talking about the event or avoid activities, people, or places that arouse memories of the trauma. This avoidance is accompanied by feelings of detachment, emptiness, and numbing. 3. Persistent symptoms of increased arousal as evidenced by irritability, difficulty sleeping, difficulty concentrating, hypervigilance, or exaggerated startle response, and alterations in mood such as chronic depression, negative appraisals, and lack of interest in previously pleasurable activities. Now, these patients often also experience somatic symptoms or sympathetic nervous system arousal that can be confusing and it can be distressing. So you need to explain to them that the physical symptoms are related to their psychological state. This will help decrease powerlessness over the symptoms and help instill a sense of hope in your patients. So further, some examples here. Events that can cause the development of PTSD include military or hostage situations, crime-related events, natural disasters, and human disasters and accidents. So digging a little bit deeper, military combat, prisoner of war experience, or being taken hostage, crime-related events such as bombing, assault, mugging, or rape, natural disasters such as floods, tornadoes, and earthquakes, human disasters such as automobile, airline, and train accidents. And an often overlooked cause of PTSD is being diagnosed with a life-threatening illness or being treated for a serious illness, particularly in the intensive care unit. PTSD symptoms can begin a month after exposure, but a symptom delay of months to years is not uncommon. So epidemiology, about 60% of men and 50% of women have at least one trauma in their lifetime. However, not everyone who experiences a traumatic event will develop PTSD. Comorbidities are major depressive disorder, anxiety disorder, sleep disorders, and dissociative disorders. Risk factors are similar to those seen in children, so refer to previous slides. In clinical manifestation, again, flashbacks, because these flashbacks and this hypervigilance of PTSD can be terrifying. Avoidance of stimuli associated with the trauma, persistent symptoms of increased arousal, and alterations in mood. Sometimes the patient may have symptoms shortly after the exposure, but other times it may be delayed again for months or even years. These symptoms begin to interfere with their interpersonal relationships and their daily lives. So assessment, there are two different screening tools. There is the primary care PTSD screen, which is a 5-item screen used to identify patients with probable PTSD in the primary care setting, and then the PTSD checklist, which is a 20-item self-report measure. If the screening is positive, then a more comprehensive assessment will be necessary. Your nursing diagnoses will be anxiety, impaired coping, social isolation, insomnia, sleep deprivation, hopelessness, chronic low self-esteem, and a self-care deficit. Your outcomes, you want to see the patient manage their anxiety, experience enhanced self-esteem, and exhibit an enhanced ability to cope. Implementation, treatment is the same as previously described for children. And evaluation, the patient recognizes symptoms as related to the trauma. The patient is able to use newly learned strategies to manage anxiety. The patient experiences no flashbacks or intrusive thoughts about the traumatic event. The patient is able to sleep adequately without nightmares. The patient can assume usual roles and maintain satisfying interpersonal relationships. Now, our treatment modalities, pharmacotherapy, specifically SSRIs, have been approved, and these include things like sertraline and paroxetine. Now, atypical antipsychotics are not recommended to treat PTSD. And then you have your psychological therapies. The primary treatment is going to be trauma-focused psychotherapy, but it also can include brief psychodynamic psychotherapy, imagery, relaxation techniques, hypnosis, and even group therapy. Okay, moving on to acute stress disorder. It develops after exposure to a highly traumatic event. It is diagnosed 3 days to 1 month after the event, and it must have 8 of these 14 symptoms listed here on page 302. A subjective sense of numbing, derealization, inability to remember at least one important aspect of the event, intrusive distressing memories of the event, recurrent distressing dreams, feelings as if the event is recurring, intense prolonged distress or physiological reactivity, avoidance of thoughts or feelings about the event, sleep disturbances, hypervigilance, irritable, angry, or aggressive behavior, exaggerated startle response, and agitation or restlessness. So your assessment is similar to the assessment for PTSD. And your highest priority is post-trauma response when you're looking at your nursing diagnoses. As far as your outcomes, you want to see a desire, for a reduced response to the trauma, improved adaptation and decreased anxiety. Implementation, you should establish a therapeutic relationship, assist to problem solve, connect person to supports, educate about therapies. I forgot what ASD stands for, y'all. My mind is blank, sorry. Collaborate for coordination of care, ensure and maintain safety, and monitor response and adherence to treatment. Evaluation is also similar to that for PTSD. Okay, so let's talk about ASD, acute stress disorder, sorry about the other slide, and PTSD. So your ASD symptoms last between 3 days and a month. PTSD is going to go beyond a month. ASD is typically caused by a recent traumatic event. PTSD can develop after a traumatic event that occurred months or years ago. ASD treatment focuses on managing and alleviating symptoms during the acute phase, and PTSD treatment often involves more long-term therapeutic intervention. Your treatment modalities, again, the cognitive behavioral therapy. We've already talked about EMDR therapy. But know that research has shown a reduction in the development of PTSD for those with an acute stress disorder if it's treated. Adjustment disorders. An adjustment disorder is an emotional or behavioral reaction to a stressful event or change in a person's life, but it is milder than acute stress disorder and PTSD. The reaction is considered an unhealthy or excessive response to the event or change within 3 months of it happening. For the symptoms, you can see here: violent behavior, dangerous driving, alcohol abuse, withdrawing from friends and family, sleep issues, depression, anxiety, suicidal thoughts, and behavior. Treatment. Psychotherapy is the standard treatment. And you treat the depressive symptoms with antidepressant and anxiety symptoms with your benzodiazepines. Dissociative disorders. Disassociation is an unconscious defense mechanism that protects the individual against overwhelming anxiety through an emotional separation. However, this separation results in disturbances in memory, consciousness, self-identity, and perception. Now, there may be mild, fleeting dissociative experiences, and those are really relatively common for all of us. For example, we say we are on autopilot when we drive home from work and cannot recall the last 15 minutes before we reach the house. These common experiences are distinctly different from the processes of pathological disassociation. Disassociation is involuntary and results in failure of the normal control over a person's mental processes and normal integration of conscious awareness. Dimensions of memory that should be linked are not and are fragmented. For example, a person may be aware of a sound or a smell, but these sensations would not be linked to the actual event itself, leaving the person fearful and or confused. In addition, the person may reenact as well as re-experience its trauma without consciously knowing why. Dissociative disorders are a disconnection and lack of continuity between thoughts, memories, surroundings, actions, and identity. So people escape reality in ways that are involuntary and unhealthy, which cause problems with functioning in daily life. Usually this occurs after a traumatic event and is used as an unconscious defense mechanism. But there are cultural considerations. There are certain culture-bound disorders that exist in which there is a high level of activity, a trance-like state, and running or fleeing, followed by exhaustion, sleep, and amnesia regarding the episode. These syndromes include Piblota, which is seen in Native people of the Arctic, frenzy witchcraft among the Navajo, and amok among Western Pacific natives. These syndromes, if observed in individuals native to the corresponding geographical areas, should be differentiated from a dissociative disorder. So our epidemiology, the prevalence is between 2 to 10% of the population. Most often patients seek treatment for another disorder, such as anxiety and depression. Risk factors, biological, genetics may play a small role, but detachment from the caregiver can also be a neurobiological cause. Cognitive, disassociation is a defense mechanism using separate parts of the personality that are not fully integrated, each becoming dominant depending on the situation. In environmental, the main reason for development is the response to an overwhelming traumatic event. Dissociative amnesia is a disorder characterized by retrospectively reported memory gaps which involve an inability to recall personal information, usually of a traumatic or a stressful event. In dissociative amnesia, autobiographical memory is available but is not accessible. In contrast, a patient with generalized amnesia is unable to recall information about their life. The amnesia may also be localized, so the patient is unable to remember all events in a certain period, or it can be selective when the patient is able to recall some but not all events in a certain period. Dissociative fugue is a temporary state where a person has amnesia and ends up in an unexpected place with the inability to recall identity. Treatment, usually dissociative amnesia resolves spontaneously after being removed from the traumatic event, but anxiety medicines like your benzos can be used short term. Depersonalization, derealization disorder is a persistent or recurrent episodes of the depersonalization. The focus is on self. You're extremely uncomfortable feeling of being an observer of your own body and your mental processes. Derealization, the focus is on the outside world, recurring feelings that one's surroundings are unreal or distant. The person feels as if walking around in a fog, bubble, or dream. Treatment, again, this usually resolves on its own. However, cognitive behavioral therapy and self-hypnosis have been successful along with medications. Dissociative identity disorder was previously called multiple personalities disorder, and it is defined by the presence of two or more distinct personality states. These different personalities control the individual's behavior, and it likely stems from a traumatic event in childhood. Now, there are two different states, one that is the functional daily state, and the other is the alter state, which is fixated on traumatic memories. Each personality or alter has its own pattern of perceiving, relating to, and thinking about self and the environment. Usually the transition between personalities occurs during times of stress. And then you have cognitive distortion, which is an insistence that the alters inhabit separate bodies and are unaffected by the action of the other. Okay, so application of the nursing process, assessment. First of all, before you begin your nursing process, other medical and neurobiological conditions need to be ruled out first. So your assessment. The nurse should perform a memory assessment, past history, assess the patient's current mood, what impact this has had on the patient and family, their suicide risk, and remember to always perform a personal self-assessment. Nursing diagnoses, examples include disturbed personality identity, impaired role performance, and anxiety. Outcomes, you want to improve personal identity, improve role performance, and reduce anxiety. The overall goal is the integration of personalities into a single personality. And your planning has 3 phases. Phase 1 is safety, stabilization, and symptom reduction. Phase 2 is confronting and integrating traumatic memories. And phase 3 is identify, integration, and rehabilitation. So your implementation, process of integration and linking previously disconnected neural networks, interventions offering emotional presence, and help teaching information include normalize experiences by explaining symptoms or adaptive responses to past overwhelming events, and teach grounding techniques. So grounding techniques. These bring the person's awareness to noticing real things in the present, which help to counter those dissociative episodes. You can see examples in our book here on page 309. Right here. Evaluation. Treatment effectiveness is related to integration, which is the individual develops the ability to function at a high level amidst the different personalities. Treatment is considered successful when outcomes are met, patient safety has been maintained, anxiety is reduced, integration of fragmented memories, new coping strategies, and stress is handled adaptively without use of disassociation. Treatment. There are no specific medications to treat dissociative disorders, but there are medications to help with the hyperarousal and intrusive symptoms. Psychological therapies, you can see multiple options listed here on the slide. And then somatic therapy. So this connects a person's mind and body to apply psychotherapy and physical therapies during treatment. Examples will include breath work, meditation, visualization, massage, grounding, dance, and or sensation awareness. A nurse is involved in a serious and prolonged mass casualty incident in the ED. Which of the following strategies should the nurse use to help prevent developing a trauma-related disorder? Select all that apply. B, C, and E. Take breaks during the incident for food and water. debrief with others following the incident, and take advantage of offered counseling.